creation of this global neuropsychiatry group, which we're very pleased about respecting the person and what we can do to help treat the person. And it's also very important, especially in countries like India or other countries where the cultural context is much bigger and where there's a significant socio-economic gap as well. How do we help the patients, or how do we help the community in these countries? So I think I'm very looking forward to hearing views of my expert colleagues in what can we do to help people in countries like India where there's just a big socioeconomic gap, lack of psychoeducation, a lot of myths around various concepts. So yeah, that's from me.
Thank you, Jess. I'd like to ask Jay, you and a child can be also very complex because you have some of the neurodevelopmental features that coexist with epilepsy, but you will also have things like depression or anxiety in a child with epilepsy. So how does one go about, in the right way, making a diagnosis in these circumstances of complex coexisting conditions?
Wow, it sounds very difficult. I think the right way is to understand that children are a moving target. One day to the next, 1 year to the next, everything can change. And that's the magic and the challenge of development, after all. And the other thing to really appreciate is that development does not occur in a straight line. The usual routine, in fact, normality, if you will, is 3 steps forward, 2 steps back. So if you're seeing a child when they're in the 2 steps back phase for mood, anxiety, social relationships, whatever else, then it may not be accurate. So the most important thing is to have serial visits through time. Don't make assumptions based on the initial visit. As Dr. Cogdill was saying, a 30-minute visit isn't going to do it. We're going to have several different visits. Now, the epilepsy itself is complicated, and I think it's getting more complicated because what we realize is that EEG, electroencephalogram, is a very crude tool. It is not magic. Now, there are ways to enhance the yield to identify seizures. We can do all sorts of techniques, ventilation, sleep deprivation, etc. But it's still not foolproof. And I think we have a lot to learn about EEG, particularly in kids, but also in adults, really. But I think that what we see is that there might be an electrical signal for other types of mood or anxiety states. We just don't know that yet. So there's no magic to it, Christian. I think the main thing is serial visits through time, get as much information as possible. And the old saying, if you're not sure what's going on, then ask, get another consultant or get some more information, get another informant. That's always going to be the routine. It's not going to be a questionnaire or form, but it's going to be someone who knows the child. Bring in a grandparent, bring in a child and their friends. I sometimes learn a lot by having children come with their friends, or see a video of the behavior. That can also be very informative. No shortcuts. That's the main thing.
Thank you. Kurt, one of the challenges of FND, of course, is that it's so difficult to diagnose. And it's almost a diagnosis of exclusion because we have to go through a number of steps to rule out what we think are organic causes before we decide that what the person is presenting with is a functional neurological disorder. How does one go from this being a diagnosis of exclusion to a diagnosis of inclusion? What are the red flags? And I think this matters as much to people, sufferers and their families, because how do you sort of educate people to understand that what you have does not require you to keep rushing to hospital, rushing to different doctors. It needs you to engage in therapy.
A lot of times when big changes are made, it's because of what we call a paradigm shift. And for that diagnosis to go from diagnosis of exclusion to diagnosis of inclusion, there was a paradigm shift. What I mean by that is that in the United States and other countries will use a book called the DSM, the Diagnostics and Statistics Manual of Diagnoses. It's not used everywhere, but it's what a lot of the work that we use does. There are different editions. There's the DSM-4, the 4th edition, and then now there's the DSM-5, and then there's even the DSM-5 text revision, so they keep revising them over time as we learn more and more about different diagnoses. To answer your question, in DSM-4, it was a diagnosis of exclusion. What I mean by that is there are certain diagnostic criteria that you go by. One of the criteria was that there has to be evidence of a psychological issue that is contributing to the symptoms. Another was you had to rule out malingering. Malingering, as you know, means faking. So the only way to rule out malingering is to have surveillance, where you see the person comes in and they are doing this, they do have a symptom, and then you get the video when they're not looking and they don't have it. And so then you think, might they be doing this intentionally? That's not the people we're talking about. This is a conversion disorder, or where the unconscious has an expression of the physical symptoms. They're not doing it intentionally, they're not faking. In clinical practice, however, we typically don't do surveillance. That's more forensic work, so we couldn't meet that criterion. Secondly, a lot of times, time is a big issue that's been discussed here. A lot of times in the emergency room, you have 30 minutes with a patient, and they can't move their leg, and they eat, and the head imaging is negative, but they don't know you. They don't trust you enough to talk about what that conflict could have been, or that history of traumatic history, so you can't meet that criteria. So that was why it was a diagnosis of exclusion. Fast forward to DSM-5. We actually took those very important criteria and said that they're not diagnostic. They were relegated them to a note. They're important. You want to make sure that the person's not thinking. Very few people are who have these symptoms. And also you want to know that there is some past history that's important, but you might not get it in that brief encounter. What we did do is that we use signs and symptoms on the neurological exam that are not consistent with neuroanatomical and neurophysiologic pathways. So we see those types of exam findings that we can teach to our colleagues to be able to use those as positive signs. Now we've got it as a diagnosis of inclusion. And it's changed the landscape with that paradigm shift of being able to walk in and say, this is a functional neurological disorder, conversion disorder. We've got your imaging, we've taken your history, we've spent some time, we've got your exam. We can say with a high level of confidence that we know what you've got. And the good news is there's treatment for that, and it's available for you.
Thank you. So you can already see the shift happening. David, one of the challenges that we face is when we are dealing with a very hyperactive child, it's very obvious. But inattention goes missed for very prolonged periods of time, and sometimes we pick up inattention as part of ADHD much later. So I wanted to ask you about that, but I also want to ask you, what role does the education system play in terms of dealing with children with ADHD?
Well, on the first question, very important, and that's why our recognition of ADHD in girls and women has been delayed, I would say, because many of I do see some girls who are extremely hyperactive and impulsive. I see someone smiling there, they maybe recognize that. But I also see lots of girls and women for who the hyperactivity is not so visible. But when you talk to them, they very clearly describe their difficulties in focus and attention. And I think the two parts of your question quite meaningfully are linked. Because you don't see the inattention as well. In the classroom, it's the girl or the boy with inattention who drifts to the back of the class, who isn't catching the teacher's attention all of the time, but who is struggling with their work and not being as productive as actually you assess they should be otherwise. But the real key is to talk, is to ask. Because when you ask people, is this a difficulty staying on task? How are you with your organisation? Are you someone who's forgetful and loses things? And not just asking the child or young person themselves, but those around them. And it dawns on them, oh gosh, yeah, that's a real difficulty. And so asking the questions, that's why that clinical interview is so important. But if you're screening someone and thinking, could ADHD be part of the problem here? Then yeah, thinking about concentration, focus, distractibility, organisation, memory, losing stuff. For schools can play a key role. Unfortunately, I don't know what it's like in India, I doubt it's much better than Australia. Teachers get about 1 hour on ADHD in the whole of their training. And yet, there's going to be one child in every class, if you've got a class of 30, who has ADHD. And so actually one of the things looking forward that we're doing is developing a virtual reality program for training teachers how to recognize what is inattention and what is oppositionality. Is it a child refusing to pay attention? Or, as we've talked here about, are they distracted by the devices and even the computer screens that they're using? Or is this a child who's actually trying hard to focus and pay attention, but can't? And that's a work in progress. Once we've taught the teachers better how to recognise, then of course we've got to help them to manage those behaviours. But yeah, education is key.
Thank you. Vivek, we've talked about ADHD, we've talked about FND, and we've talked about epilepsy and behavior. How is neurotechnology changing our approach to the care of many of these conditions?
The most important part, like in last 9 years, when we are doing the neuromodulation, and last, before that, roughly 15 years of integrated care, there are technology. For example, yesterday when we were talking about the treatment for fibromyalgia and the TMS, now there were new trials what came out this year, like Silva 2025, which produced a protocol which lasts over about 12 weeks. And we have already tried those protocols at the clinic, and we found that the patients are achieving the remission not only better but faster. I think that's the role of technology. Yesterday, a few of the presentation says that it's not just can we achieve a treatment goal, but can it be faster? Can it be more sustainable without the usual side effect of the traditional pharmacotherapy treatment alone? I think the fibromyalgia, FND, there is definitely a big scope. Second, dysautonomia. Now we are seeing dysautonomia in FND, we are seeing in Parkinson's disease, and the role of the vagus nerve stimulation, non-invasive. We do look for the patients who are not responding to the traditional system. They are getting the physical therapy under one roof. So that's, I think, the key highlight, that technology alone don't serve the purpose when it's like addition with the scope like of physical therapy, if it's a psychological, doing the clinical psychology evaluation, going for the psychotherapy. So integrating technology is the key, not just the technology alone. And with the range of technologies we get, so when we are looking for integrating the TMS, TDCS, but what about the TACS, the transcranial alternate current stimulation for sleep? We are talking about transcranial random noise stimulation for Parkinson's. So that again, going for ADHD, though the evidence is mild, but we do look for the effect of TDCS in the patients with even at late stages. Then they come in I would classify them in pediatric, but 18 and above, and they say that we feel much better. And again, based on the ratings on the scales. So I think bringing technology under one roof where they can simultaneously work with the physical therapist, the psychologist, the holistic care, and get their pharmacotherapy in one place. I think that's what makes the difference. So in fact, many of the presentations we've had yesterday and what everyone's spoken this morning is pointing towards the need for a comprehensive approach, a need for holism in care from diagnosis to treatment. But we do lack, shall I say, formal paradigms that everyone can adopt. So we don't have plug and play models or protocols for comprehensive care that people can adopt. And I'd like to ask everyone on the panel to comment on how you think comprehensive care paradigms can evolve in such a way that they become applicable across the world.
Maybe I'll answer slightly tangentially. It's something I wanted to say at the beginning. I had a lot of involvement in developing evidence-based guidelines across a wide range of conditions, and emphasizing the process of the evidence-based guideline rather than just the consensus guideline that we develop in a smoky room with old guys like us putting that together. But one of the things that I've learned from that is that we do have a lot of paradigms, we just don't put them together. And one of the other things that I hear often from my colleagues is, well, my patients don't fit into the guideline. My patients are too complex for your guideline. And my answer to that is that's actually when you need the guideline. Because if your patient is too complex, too unique, if all your patients are too complex and too unique, you have no rule to follow. Every single person is different, and therefore there is no general knowledge that you can follow. And so I coined for me a phrase of deconstructing complexity. And one of the things that I think that comprehensive assessment is deconstructing the complexity into bits that you understand, and then you can start to decide for this person with these problems, which is the order in which I'm going to approach them. And then you approach them following the best evidence. It's not always going to work first time, and you're not always going to get it right first time, but you have a path to follow. And so that would be my answer. It's about take what we've got, pull it apart a bit, and then reconstruct it into your model.
Thank you.
I think that's sound reasoning. That sounds terrific. May I propose just a very old-fashioned approach, which is that we have to have a dialogue. We talk to each other. Clinicians need to talk to each other. I can't tell you how many times a family or a patient or someone else is so appreciative that I'll actually talk to someone's neurologist, because it just doesn't seem to happen. I'm not sure why. I'm sure there are many reasons about lack of time or something else, but that's what families want, patients want. They want people to talk to each other. What if it is the expectation that every psychiatrist and every neurologist for a patient with epilepsy will communicate in real time for each visit? Would that be acceptable? I think it would be ideal. And there are many examples through the way. We can bring in the rehab person, we can bring in a psychologist, we can bring in a teacher. The more people talk to each other, I think that advances our paradigm, at least when it comes to pragmatics.
Thank you. Good.
Jess made a comment a minute ago that might have slipped by. He said, I'll paraphrase, we're not just treating a diagnosis, we're treating a person. He's talking about the personhood. We are losing, I believe, in modern medicine, the personhood and the humanity in our patients as we become more and more technologic. I'm not saying that we don't need to use or shouldn't pay attention to technology. I'm saying pay attention to the person, the human being who's sitting in front of you. How many of you in the audience are clinicians? All right, so you might have had this training already. If you haven't, I'm going to give you a little pearl. At Brown University, we have some of the greatest advances in neurotechnology and in neuromodulation and in neuroimaging and in neuropharmacology and in neurobehavioral therapy. We've got all that. Along with doing that, they asked me to teach spirituality and medicine to the residents. Here's the importance of spirituality and medicine. When you're taking Jay was talking about having a dialogue, get to know your patient. As you're taking your social history, tell me about growing up. What was it like? Tell me about your parents. How many siblings? How about education history? Finding out the comprehensive education history. Any problems in school? Did you ever have any setbacks? You talk about work, social life. Tell me about your relationships. Continue in the social history. Any alcohol, drugs, substance use. Continue in the social history. How about any legal issues or charges against you? Any military service and any exposures? What's your family's faith? Do you practice? Including those two simple questions in the dialogue as you're taking the comprehensive history, you hear about one of the most important factors in our patients that gets overlooked in medicine so often. And so then you find out, oh, you know what? I used to believe that there was a God, but then after being exposed to the fog of war, I can't believe that there can be a compassionate God. And that's part of the medical data that you are going to incorporate as you understand the person from a whole person perspective. Then when it comes around the time of addressing the trauma history, you could say, you mentioned that your faith was important to you in the past, that you moved away from it. Tell me more about that. When you do that, then you find out the moral injury that the individual experienced because of the horrific things that they were part of. The treatment is not through a pill or even through the best evidence-based psychotherapy. The treatment in this case is forgiveness. I prescribe forgiveness to many of my patients to address their core issue. That's part of good medicine, taking care of the whole patient, biological, psychological, and social, and spiritual.
I had something to add to that. I kind of take all of that on board. And I don't buy into all of our new languages that we're asked to speak, but one of the ones that I have taken on board is remembering that the people that come to see us as clinicians are only patients when they're with us. For the rest of their lives, they're people. And so I've actually really stopped talking about patients and started to always remind myself that we're talking we're talking about people. And it sounds like a little step, but actually I think it's very meaningful on how respectful we are about the people who we work with and who are working with us.
Thank you. Yes. Thanks, Krish. Yeah, I think thanks, Kurt, for emphasizing more on treating individual as a person, as a human being. And how I say it is, I think the responsibility sits on you as an adult to understand what is happening here and try to make sense of it and look for the right resources. And then I think in Indian context, or for that matter, I think in any family, I think the care fatigue, care burden is a big thing. But that's where the role of care comes in. It's about supporting the individual, listening to the individual. I was really shocked by one of my colleagues who's a pediatrician, whose daughter was having problems with inattention. So she couldn't concentrate in the class and came across this video, a TikTok video on ADHD, and told her parents, hey, looks like I've got this condition. And the parents said, no, there's nothing like ADHD in girls. And so she wasn't listened to, number one. Her performance dropped. Not only because of ADHD, but because she wasn't listened to. I think so as a carer, it's so important to listen, to understand what's happening, and look for the right resources to make sense of things. And I think the other paradigm shift which needs to happen in India, which I have seen growing up as well, I think there's a lot of hesitancy, amongst patients, amongst family members to ask the clinician, hey sir, what is happening there? I don't understand why this person being medicated is still not getting better with epilepsy, or for that matter with any other condition. So I think that paradigm shift needs to happen, where you need to take a onus to ask the clinician, hey, why I'm not getting better? Why is this happening? What will be the explanation? I think as a clinician, India is a very different platform when it comes to managing patients. I guess in 4 hours you will be seeing 100 patients. But I think that's where you need to be more mindful of, the pledge we take when we graduate is do no harm. If the person is not getting better, hey, what is happening here? Where is my limitation? Shall I refer him to a psychiatrist, psychologist, or someone else? So I think that's what I want to emphasize upon is it's listening, finding the right resources, and being mindful of your own limitations as clinicians, and do your best to help the patient.
Thank you. If anyone has questions, I think we're quite happy to take a couple of questions. Dr. Rama?
In our approach with neurobehavioral therapy, which is a multimodality, time-limited, workbook manualized, whole-person integrative therapy, where we take the best of each of the different psychotherapy modalities and we match it to the known pathologies in our individual patients with FND. So we equip them with skills and tools so that they have a tool belt that they'll be able to use in whatever situation they encounter. I tell them it's 12 sessions, 1 hour per week. We'll meet to discuss the work that you've done in the workbook, taking control of your seizures. And this is work that you've done. And I'm here. Your job is to do the work. My job is to walk alongside of you or abide with the patient. At the end of that, you'll be fully equipped with tools. And in fact, I'm trying to work myself out of a job. I don't want you to have to come back and see me. I don't want you to be a professional patient. Now, having said that, many of them do get these tools and skills and they go on and live their life. The key is not at the beginning when we say, what is taking control mean to you? What it doesn't mean is, I'm never going to have another symptom ever again in my entire life. We don't do that. We don't promise that for most patients with epilepsy. Some people become seizure-free, but 30% continue to have seizures, even on the best medications. We don't say that for diabetes, hypertension. These are chronic issues. What you do is you equip them with self-management and self-efficacy to help them live a high quality of life, even if the symptoms are there or not. Sometimes when they do have exacerbations because of a life event or some other problem, fine, they can come in for a booster session or maintenance. But I try and let my patients know you've got what it takes now to live your life.
Thank you. Anyone else? Are there any questions? Yes.
Good morning all. With a quick intro, I am not a clinician, I am not a therapist. Thanks to UKS for allowing me to be part of this intellectual crowd. I am a technologist. I build healthcare systems, primarily age tech related systems. My question to all of you is, there is a big paradigm shift in the industry that I come from, right? From artificial intelligence to generative intelligence. And no more it is an artificial intelligence, it's being more compassionate and more human when it comes to healthcare. So how do you see generative AI, creating impact into non-clinical therapeutic sessions in neurology, disorders? Question number 1. Question number 2 is, as a technologist, I have the responsibility to create the typical guardrails where the conversational interactions would help the patients, and then where should I stop and leave it for clinical intervention? So how do we draw the lines? These are the questions.
Who's taking the tech question?
Well, see, technology, I truly believe in the technology that, the technology helps it or help us find the solution. So like when we are talking about what we should be doing with the technology, and as of now, like there are some AI systems which are integrated in a healthcare systems, I think in US, and now there are guidelines which is being developed that what the AI should do. See, being an over compassionate or under compassionate don't serve the purpose here, but it is what right kind or what right level of compassion the chatbots have to be towards the patients. But more likely, they are the assistive tools. See, though like everyone use advanced LLMs these days, and it's not that, see, there are two things. One, a therapist with LLM and a therapist without an LLM. So it's not the LLMs or the AI or Gen AI is going to replace it. They are going to be as a tool to assist the therapist to perform their task better. But we have to just put a line that what are the guidelines. So as we just spoke about the guidelines, and there are, I think the guidelines are in picture which all are getting better as we more understand about it, that what the Gen AI should able to do and what are the restraints we have to put up. Because if not, I think there was a recent very negative news about the Gen AI guiding a 16-year-old kid. But again, it have to be more restrained. Just like the diagnosis manuals, there should be AI manuals for healthcare. I think that's what we will.
That's a fascinating question. Actually, I like computer models and circuit design, and that's probably what got me interested in epilepsy in the first place. The brain being at least an analogy to how computer networks sometimes work in terms of the feedback loops and feed forward and everything else. So I'll just mention two things. One is the caveat, which is I have patients that use ChatGPT as their therapist, and it actually makes them feel better. I can't deny that, and I think that's an important tool that we have to accept, and it sounds appropriate. I do see cautions on several levels. One is are we going to allow AI to improve autonomously and to sort of improve the AI model? So AI building new AI, that sort of thing. That could be a big problem, not just for us as clinicians, but for us as a human society. And I don't think anyone who underestimates the power of that and the risk of that simply doesn't understand how computers work. Because that is possible with the computing power that we have. We never thought that we would be able to design weapons that could destroy the world. AI has that kind of power. The other thing with healthcare, though, is that we have to be very cautious about what happens during the session. I think that right now we can transcribe word for word, patient sessions, and then make a clinical note. The end point of that is because it helps clinicians efficiently make a clinical note and document appropriately. But I think there's a major privacy concern with that. Number one, we have to have a patient's permission and not just, yes, doctor, I'll do whatever you tell me to do, because that will happen many, many times. But then who owns that content? Is that content then allowed to improve the LLM? I'm not so sure that anybody's opting into that. So when you think about guardrails and stuff like that, I think there have to be very clear lines about how this influences our day-to-day practice. And sure, if we're going to search and look at all known literature on such and such, fine. But when it comes to actually using those models to interpret and communicate what we do, what we think, who we are, then I think there are other issues that will emerge.
I think we're sort of coming to a time when we should close, because we have a session at 11 o'clock, so there are no further questions. I think I'm going to ask the organizers to.
So we can felicitate the speakers.
Ma'am, look here, ma'am. Yeah.
here?
to invite Dr. Nagraj to honor Professor Karat's.
Sir, okay.
Professor Jasmine. Because something.
Kevin, sir, Kevin, sir. Yes, sir. Yeah. Yes, sir. Yeah. Sir, look here, sir.